Welcome to the weekly Cerebrovascular and Skull-Based Symposium at the University of Miami. This is our 9th session now in a row. I'm Jacques Morcos, professor and co-chair of the Department of Neurosurgery and Otolaryngology, director of vascular and skull-based surgery. I am delighted to have as co-directors of this course, Carolina Benjamin, who's specializing in brain tumor and skull-based surgery at University of Miami and at Jackson North Hospital, as well as Michael Ivan, assistant professor, director of research, Brain Tumor Initiative, specializing in brain tumor, skull-based and epilepsy surgery, as well as my two endovascular and open vascular partners, Bobby Stark and Eric Peterson. This is beautiful Miami. This is our medical center, University of Miami Hospital, Jackson Memorial Hospital. We're a tertiary referral center for not only cerebrovascular and skull-based diseases, but many other specialties. This is the website where you can register and see what our educational offerings we have. These are all the lectures we've already done. We are here today on July 16, and there are many more to come, and you can see all that on our website. Can you still hear me, Roberto?
Yep.
Okay, because I am unable to stop sharing the slides, but maybe we'll do that later. I'd like to invite you next week to our session, very exciting, about AVM embolization with Mustafa Bashkaya and Adam Arthur. Should we or should we not use it? I'd like to also invite you on the Wednesday symposium that my partner Mike Ivan runs, and I co-direct with Rick Komotar and Carolina Benjamin. And next week is very exciting lecture by Jason Sheehan on SRS for brain mets, myth and facts. I'd like to thank our team, Roberto, Ingrid, Christina, and Ignacio, for helping us put these weekly sessions together. This is how you connect with us. This is how you can reach me. You can reach Ingrid Menendez in our department for any educational questions you may have. Some housekeeping rules. Use the Q&A box to send your questions, and we will certainly discuss them at the end of the speakers' presentations. We do not offer CMEs. Please share this information in your social media if you think it is worthwhile. Our speakers will speak each for 25 minutes. I'll give them a 2-minute warning before the end, and then our panelists will show their cases as we do every year. So now the pleasant part of the evening is for me to introduce my colleagues and friends who are here today. I'll start with Tiet Mathiesen, who is a professor of neurosurgery at the University of Copenhagen in Denmark. He spent a lot of his career at the Karolinska, but recently moved to Copenhagen. Of course, he's editor-in-chief of ACTA and a skull-base expert. And thank you, Tiet, for being here. I'd like to then welcome Torsten Meling, who is professor of neurosurgery at the University of Geneva in Switzerland. Also spent most of his career in Norway, where he's from, and again moved recently to Geneva to continue his skull-base and vascular career there. And both Tiet and Torsten have been fundamental to the ENS, the educational activities of the ENS. And again, thank you very much for your friendship, both of you, and for being here today. Sean Raza, Associate Professor of Neurosurgery at the University of Texas at MD Anderson. And the biggest mistake I've made is not taking Sean as my fellow many years ago when he was looking for a fellowship. And he's certainly shown me what he is capable of doing as he has become a spectacular educator, surgeon, and is very active in the North American Skull-Based Society. Sean, thank you for being here today. Georgios Zenonos, who
Marcos,
is...
I'm sorry to interrupt. I don't think we're not seeing your slides.
We're just seeing you at this point. I don't know.
Really?
Yeah. Maybe share and unshare.
Okay.
We like seeing you, but
Really, you don't see my slides?
No.
Okay.
Hit share, share your screen again, Dr. Morcos.
Okay. Well, thank you for telling me. Okay. How about?
There you go.
Oh, really? Okay. You see the slide now?
Yeah.
Yeah.
Okay. Nope. Oh, I'm sorry. I don't know what happened. Sorry about that. Okay. George was my fellow 2 years ago, has returned, is now assistant professor of neurosurgery, University of Pittsburgh. Was a phenomenal fellow. I cannot speak enough about George and his forging his own path in cerebrovascular, endoscopic, and open skull base surgery at UPMC with Paul Gardner and the whole group. And I'm sure he will dazzle us with his presentation today. Now, I'd like to welcome our two speakers. Untitled Professor and Vice Chair of Department of Neurosurgery, University of Washington, Seattle. I really don't need to present him, to introduce him, but I will. He is known around the world. He was born in Madras, India, got his MBBS, Madras Medical College, residency, University of Pittsburgh in 1982. He did several fellowships, and if there are young people listening today who are starting their path in neurosurgery, this is how it was done, and this is probably how it should be done. He did a fellowship with Majid Sami, with Ghazi Yazargil. He visited Derome, visited Lindsay Simon, all of that in 1982, 83, after finishing his residency, to acquire more skills, to see more people. He then, several years later, did endovascular fellowship over a 5-year period in Washington. He's been through several places. This is his 4th place, University of Pittsburgh, George Washington University, North Shore University, but has been now at UW since 2005. Phenomenal talent. Sheikh truly pioneered the field of skull base in the 80s, just as an assistant professor, and has made fundamental contributions to the field as well as cerebrovascular surgery. You can see probably his 2 foremost mentors right there, Peter Janetta, Majid Sami, but I'm sure he counts several others. He has hundreds of publications, and he will, and I'm delighted, Sheikh, that you could spare the time to be with us today. Ricardo Ramina. Ricardo is professor and chair, Department of Neurosurgery at Neurological Institute of Curitiba in Brazil. He was, of course, born in Brazil, residency in Hanover with Majid Sami. That's what they have in common, the lineage, he and Sheikh. He, from 86 to 2004, he was chair at Nassau's Hospital in Curitiba, became associate professor ad hoc at the GW University from 93 to 99, became director of skull base at the State University of Campinas in Sao Paulo, Brazil, professor and chair in Curitiba at the Neurological Institute since 2004, also since 2006, professor of Pontifical Catholic University of Curitiba, has published widely. That's, you can see there, one of his books, Jugular Tumors of Jugular Foramen. He co-wrote with Marcos Tatajiba, who also shared the lineage of Majid Sami. You can see a picture there at the 2nd Majid Sami Society meeting that was held in Curitiba. Phenomenal experience in all things skull base. So I apologize for the not showing the slides earlier, but I'm not going to waste your time and show them to you again. So I'd like to stop now and invite Sheikh to share his slide.
Let's see here. Good afternoon. Gentlemen, can you see the slides?
No, not yet, Sheikh. Do it again. The green box.
Not sure why.
Yeah, I'm not sure why I had the same problem too. Interesting. Yeah.
It's
It's
showing now?
good. It's coming. Yes, exactly. And just on the regular slideshow, if you could click that. Yeah.
Okay. Okay.
We see the slide. Yeah.
Okay, perfect. Hello again and good afternoon. Let me see. I can get this box off. I don't know how to take the box off the. Okay,
Oh,
I've got it off here. Yeah, good.
you know, if you go to the top of it, you can minimize it, that little small line.
I got it. Perfect. Okay, very good. Well, good afternoon. Once again, we'll get started and going. So the title of the talk is Evolution of a Patient-Centered Approach. I don't want to spend a lot of time about the anatomy of the cavernous sinus. Well known to a lot of you. The only thing I would like to say is that I think the various triangles, now there are more than 40 or 50 of them, I've lost count, are very interesting in anatomical studies and textbooks, but they make very little sense in the patient situation because all of the anatomy is distorted, particularly when it comes to tumors, which is where most of the action is at the present time. Nevertheless, it is very critical for young people to learn the anatomy by cadaveric dissections and the various approaches. And just going back to this previous slide, I consider the cavernous sinus to be a truncated pyramid, and there are different approaches. You can come from the lateral, superior, posterior, inferior, medial, or even the anterior approach. So a young surgeon or even older surgeons that are well-versed in this area, it's always exhilarating and interesting to go back and learn the anatomy from different approaches. So what's tricky about the cavernous sinus? The location is deep from whatever angle you approach it. The venous bleeding can be frightening. Of course, if you injure the carotid artery, it can have lots of bleeding, death, major strokes, etc. Injury to the cranial nerves can result in permanent double vision, ptosis, loss of vision, corneal ulceration, etc. You can also damage the brain from retraction or direct damage, hematomas, pituitary damage, and even by radiation, you can damage the brain, of course. And lastly, entry into the sphenoid sinus or approach through the sphenoid sinus can result in CSF leak and infection. There have been, of course, a variety of advances and evolution of cavernous sinus surgery. All of you are now familiar with that. In addition to microsurgery, we have endoscopic surgery, endovascular surgery, and radiosurgery. These are the four different ways, in addition to not doing any surgery at all. So that's about simple observation. So that's the fifth arm. There are 5 types of surgery, but there are systematic approaches that have been well worked out. We have improved knowledge of anatomy. We know how to control the venous bleeding. So we used to pack it with Surgicel or gel foam. Nowadays, we inject fibrin glue or powdered gel foam. Less effective, but it's also pretty effective. Carotid artery, we know how to dissect it. We have bypass techniques which are now well worked out, and we use them from time to time. Cranial nerve dissection and repair. Nevertheless, cranial nerves remain the major problem, and you approach cavernous sinus surgery. And then, of course, we have reconstruction to prevent CSF leakage. We do have to work with our colleagues in ophthalmology, radiology, etc. And finally, we are totally dependent on the pathology for both treatment and outcome. Now, we, of course, have major competition, but also adjuvants from radiation oncology and radiosurgery. I won't spend much time on this. Nevertheless, to state, there's definite efficacy of both modalities in controlling tumors, but there's also a number of failures, and there are some long-term side effects. Many of you know about this. Of course, what is the evolution here in the last 20 years or so? The most important evolution is our patients. Our patients demand, quote, less invasive approaches. Of course, if you were to believe people like Zenonos-Morcos, everything can be done through a pinhole. Jacques, I'm just kidding. And they do, of course, demand better results from us. So a lot of vascular lesions truly inside the cavernous sinus now have gone the endovascular route. Not to say that there's not room for surgery in some cases, mostly. With neoplasms, we are still questioning whether we should observe them, radiate them, give them radiosurgery, complete versus incomplete resection. And of course, you also have microsurgery versus endoscopic surgery that we think about. Now, just a quick word about the preoperative and intraoperative checklist in our patients. Preoperatively, we like to get a good idea about the exam and what is the patient's occupation and what are the expectations. We still like to rely a lot on MRI scans, both enhanced and T2 weighted images. CT scan is mainly useful to look at bony anatomy. For larger tumors, we do perform angiography and possible embolization. It's not always possible. And I like to get an idea of collateral circulation only for temporary occlusion, because through our own studies, we established that if you permanently occlude the carotid artery and do not revascularize, in all except young patients you can get away with it, but in older patients with tumors, you may still have a stroke. If a bypass is expected, we keep the patients on aspirin and or clopidogrel. Intraoperatively, the questions are, should you have a central line or not? Should you have blood typed and crossed? What do you monitor? Do you obtain proximal control in the cervical or petrous carotid? Do you combine a craniotomy with a orbitotomy or zygomatic osteotomy or orbitozygomatic approach? Crinoidectomy and optic nerve decompression, intra versus extradural. What is your tumor resection strategy? This is perhaps the most difficult and varied because it depends on the tumor and oftentimes on the local situation. And you should always have temporary clips and bypass instruments ready and available. When you have ready and available, they won't be needed. But if you don't, then the people will need it. You may need it. So to summarize, with regard to meningiomas and some of the other tumors, I won't talk about all of them. Just to talk first about meningiomas, the questions are, is a tumor soft or firm? That makes a difference. The collaterals of the carotid artery, cranial nerve deficits, is it a primary or recurrent tumor, prior radiotherapy, etc. And in terms of the tumors, we make a distinction between tumors which arise within the cavernous sinus, arising outside the cavernous sinus and invading it secondarily. And lastly, recurrent tumors, especially after radiotherapy. So in all of these cases, the first principle is that, do you want to observe versus operate? And secondly, should you attempt total resection or not? And the tumor consistency is very important. And the other option also is that whether you can simply perform decompression of the cranial nerves only and then go to radiosurgery or only remove the extracavernous tumor. Now, of course, with the tumors which have recurred after radiotherapy, then if the tumor is still growing, you may have the option of re-irradiating versus performing radical surgery. Now, when the tumor is not a meningioma, you had different options. I won't speak about schwannomas, which are elegant tumors to operate on. Chordomas and chondrosarcomas frequently, and another thing that I didn't talk about is pituitary tumors. When they invade the cavernous sinus, total resection is almost always feasible. Very rarely do you have carotid injuries, but I'll show you one case. With malignant tumors, then you want to know, can you achieve a good tumor control for the patient over the long term by removing the tumor inside the cavernous sinus? If that's the case, I think there is a good rationale for proceeding. So just in the last 15 years, 124 patients operated only by me. And here are the complications. Luckily, there were no deaths. 3 patients had major infections. 2 people have temporal lobe or subarachnoid hemorrhage. In ophthalmos due to the orbitotomy, which was immediately recognized in the recovery room and corrected. We had 2 graft occlusions, both were revised successfully. 2 patients had ICA injuries during surgery, both resolved without a stroke. 1 patient had a brain infarction and no CSF leaks, and cranial nerve results, most important, we have not carefully looked at them pre versus post-op. So this is, of course, an important question. So all of my recommendations can at best be described as evidence level 3. It is not a randomized or patient-matched series. All I can say is that very careful tabulation study of your own results will help you to improve your care for the patient, and you must match the treatment to the patient's expectation. Otherwise, the patient will be unhappy. So just a few quick cases. I'm keeping tabs on the time. So this is a 77-year-old patient, previously had attempted resection at another university medical center. They abandoned the operation after they found out it was very bloody. She presented with proptosis, right eye pain, headaches. She had been placed on steroids and didn't stop it for 4 years. She had poor vision in the right eye, subtotal third nerve paralysis. Now the concern was about the left eye. And cerebral angiography in her case shows that the carotid arteries compress forward, and there are some branches from the intracavernous carotid. She also has poor collateral circulation to the right side. So she was operated with some cervical carotid exposure, and I knew that this was likely to be a cavernous hemangioma, although we didn't have pathology from previously. And I thought that the likelihood of bypass is very low, and a frontotemporal and transsylvian approach, and you can see the very bloody tumor. And we are opening the superior wall of the cavernous sinus, and we'll also open the lateral wall of the cavernous sinus. So we are employing the superior approach and the lateral approach. And as the folks experienced in this area know, these tumors are very bloody and you can treat them like AVMs, but the good news is that they do dissect away from various structures. Here you can see some injection of fibrin glue to stop the venous bleeding. And we are working through the cavernous sinus. Here we found the 6th nerve and finally rolling the tumor out. The tumor was removed completely. In this case, this is the post-operative result. Nevertheless, there is some question about whether there is a remnant here. We did not go back. We are observing this patient. She did well. She had improved third nerve function, and she is able to take care of her spouse at home. So a success story. Here's another case. It's a younger man, well, 62 years old. He was being followed by an ophthalmologist, and he had a mild third nerve weakness, but in a 6-month period, the tumor had doubled in size, relatively small, but mostly inside the cavernous sinus, presenting with the almost complete third nerve paralysis. So in this case, it's not moving. Okay, there we go. And something happened. All right. So you could see that here, this is a tumor. The dura is being opened, and it is. We've done orbitotomy. We're opening the Sylvian fissure, and we are working by a mostly superior approach. The clinoid is still there. The optic nerve is being partially decompressed, but as we go along, we are removing the clinoid process intradurally, and then I'm just showing you snippets of this operation. And here's the carotid. The tumor is a softer tumor, and I'm able to remove the tumor working simply through the superior approach. And here we have the tumor coming out. This is the intracavernous, this is the extracavernous, but the intracavernous carotid artery is right here. And I'm able to dissect this tumor. And this is toward the end of the operation. The part here, of course, is a sixth nerve, can be also seen through the cavernous sinus superior approach, especially if you have a soft tumor. The downside of soft tumors is that frequently they are also quite bloody in a case like this. So in this patient, a complete resection and complete recovery of third nerve function with no recurrence after 2 years. This is a more recent case, 67-year-old woman. She had progressive diplopia for 6 years, and she got adjusted to it. But more recently, she had an abnormal sensation in the right eye. She went to the doctor, who found, and on exam, we found a complete sixth and fourth nerve paralysis and impaired sensation. The MRI now shows a very large tumor. And if you look closely at the MRI, here is the dural line. So the tumor is mostly in the Meckel's cave and the cavernous sinus. Parts of it have extruded outside. And if you look at the patient, she looks pretty good. She has a stable sixth nerve paralysis. You know, she has adjusted to it. The question is, what do you do with this patient? She was embolized very nicely by my colleague, Dr. Lewis Kim. However, she has not very good collateral circulation. So we performed an operation with proximal control and made preparation for bypass, etc. But in her case, it was a very firm and difficult tumor. I think I could have gone for total resection, but it would have risked a bypass in the 67-year-old patient. I didn't want to take any chances. And it was already the end of a long day. And I left a small piece of tumor there. And she luckily is doing very well, going home after 3 days. And we will give her radiosurgery. Then last meningioma that I show you is this case. Patient, she was treated. She came from Israel. She was treated at London Royal Marsden Hospital for this tumor. Initially it was half the size. She got radiotherapy, and then the tumor continued to grow and essentially doubled in size. And she had complete ophthalmoplegia, very severe left pain, left eye pain. So the question is what to do with her, and no collateral circulation, zero, nothing, and no ACOM, no PCOM. So the only thing here we could do is to do a bypass in this case. I could have probably gotten away with a single, but I wanted to have a little extra insurance. So first I did a bypass from the external carotid to one branch of the MCA, and then from the internal, while this was perfusing, using a vein graft to the other M2 branch. And then in a second stage, that is, I did the bypass and stopped. Second stage went in, removed the entire tumor and did a temporalis flap reconstruction here, which you can see. And she is remained tumor-free now at several years. So this is an example of fairly aggressive surgery. This is another case of a large petroclival and cavernous sinus meningioma. This man is 47 years old, presenting primarily with trigeminal neuralgia, mild cranial nerve symptoms. He was embolized, was operated in 2 stages. First stage via a frontotemporal approach and removing here the top part of the tumor. But it was a very firm and difficult tumor, and it was not my intent to be very aggressive in the cavernous sinus. This is what was left after the first operation. We went back via a transpectrosal approach to remove the lower portion of the tumor. And you could see that it's actually a very firm tumor. I'm using a CO2 laser to remove portions of the tumor. At the end of the procedure, we are left with this. Tumor is still well, definitely inside the cavernous sinus. He had a partial third, but which recovered completely. Nevertheless, he had some trigeminal loss. And we ended up giving him post-operative radiotherapy after this. And for him, it was a good result. And of course, we have to watch him for a long time. Now, this patient is the other end of the spectrum. This is a 61-year-old patient, initially presented with severe trigeminal neuralgia and ear pain. And he had this tumor, and he was sent to radiosurgery. He had radiosurgery, did pretty well. However, he came back with much worse trigeminal pain. It had gotten really much worse. Also, he was developing some signs, early signs of dementia, and there was decreased blood flow here, some evidence of infarction. And you could see that the cavernous carotid artery is severely narrowed. Collateral circulation is present, but not good cross flow by venous face. So the question here, what should we do with this particular patient? What we ended up doing here was our planned strategy was to decompress the cranial nerves. This is the left-sided operation. Basically, remove remove all of the lateral wall and decompress particularly the trigeminal nerve and in the Meckel's cave and in the lateral wall of the cavernous sinus, and remove all the extra cavernous tumor. And then in the same procedure, we performed a bypass. We used in this patient anterior tibial artery because he had no radial arteries, and saphenous vein was also not good. So it worked out very well here. This is punch arteriotomy in the external carotid, and then the suture. This patient did well initially, but he developed a significant infection. Luckily, he recovered from all of that, and he is doing well. This is what is the remnant. It's still not grown, but remember that he didn't have tumor grow so much as the pain, which was the problem. So the pain is completely relieved. He is, he's doing pretty well. So, and lastly, a few other cases, a non-meningioma. This is a patient with an extensive chondrosarcoma, petroclival and cavernous sinus. These are very nice to remove because they do dissect from the carotid artery. You just need to have the appropriate approach. And this was operated via a subtemporal and infratemporal approach. He had a complete removal. We referred him for radiotherapy, but because he had a complete resection, he elected not to have radiation, even though he was advised for it, and he is doing well. This is a patient, similar case, but she's been operated 3 times before, a chordoma, young lady with extensive tumor in the clivus and the cavernous sinus. We operated her in 2 stages. First via a lateral approach, intradural, and then an extended subfrontal approach extradurally. And I seem to have blocked out the slides, but she had a complete removal. She also got proton beam radiation. She remains free of tumor now 10 years out. So I think these are good cases. I want to show you this case as 2 potential problems. Heavily calcified, very firm, tough tumor, chondrosarcoma, and you can see the course of the carotid. And we were prepared for something here. And look here, we are just opening the cavernous sinus through the lateral wall and working, and I'm feeling very happy here, using the sonopet to the heavily ossified tumor. And I took one little bite, and lo and behold, let's see here, big bleeding. So the carotid artery, which was already, so this in real time, the only way to stop the bleeding was just to put the finger there and hold it while we put the temporary clips. We were prepared for that. We just trapped the artery And then immediately we had made preparation for a bypass. So we just performed a radial artery bypass graft, as you see here. And then we just stopped because we didn't know how the patient was going to do. He did just fine. And we came back and re-operate on him, removed pretty much the whole tumor. And then he got proton therapy and he did well. So I think I'm going to stop here. I don't know, I must be running out of time. So I do have other cases to show, but I think that we are going to be short of time. In conclusion, the surgery of the cavernous sinus has evolved both in respect to the approaches, but also the patient's expectations and our techniques. So the surgeon operating inside the cavernous sinus requires exquisite skill, which all of us have, judgment, which some of us do and some of us don't. And for the same surgeon, it varies from day to day. But what helps us with judgment is our compassion towards the patient. We do need a combination of vascular and skull-based techniques. So I strongly maintain that person cannot become a good skull-based surgeon or a vascular surgeon without being without being both. And of course, finally, new treatments, when they become available, particularly those based on anti-tumoral antibody techniques, they may change the game permanently for us. And this type of thing is for another day. This is just to provoke your interest. And I wish to thank you so much for listening. And this is from our beautiful spring in Seattle. Thank you.
Thank you, Sheikh, very much for this lovely tour of that whole area and your techniques and so forth. We'll obviously keep the questions till the end. Again, for the audience, feel free to type in your questions in the Q&A box. I invite now Ricardo Ramina to unmute his microphone and share his slides. You are still muted, Ricardo.
Now it's okay?
Perfect. Thank you.
Okay. Can you see my screen?
Yes, we can.
Thank you very much for the invitation, Jack. And you gave me a very nice job today to talk about the trigeminal schwannoma and gave Shekhar the hard part of the cavernous tumors with meningiomas, chordomas, and so on. But I like to share with you our philosophy in the treatment of these tumors and the choice of surgical approach. There is nothing to disclose. Trigeminal schwannomas are rare, but they are the second most common type of intracranial schwannomas. It's about 0.8 to 8%. In our series, it's about 5%. We have operated so far 39 cases of trigeminal schwannomas and more than 800 vestibular schwannomas. These tumors are quite rare. And they may originate from each portion of the trigeminal nerve. The highest incidence of these tumors between 38 and 40 years of age, and they are more common in women. Symptoms are usually related to the trigeminal nerve, facial pain, hypoesthesia, headaches, diplopia. But some patients remain asymptomatic, especially if you have a patient with NF2, you can have the patient both sides, trigeminal schwannomas and asymptomatic. The first surgical removal of trigeminal schwannoma is recorded by Fraser in 1980. About the anatomy, the trigeminal nerve, as everybody knows, emerges from the ventrolateral surface of the pons and runs anteriorly 1 to 2 centimeters through the CPA system to reach the petrous apex. Some vascular structures are related to the trigeminal nerve in this portion, this external portion of the nerve. The petrosal vein, the superior cerebellar artery, they are very close to the trigeminal nerve. In some cases, compressing the nerve and the patient has trigeminal neuralgia. The Gasserian ganglia is enveloped by a dural deflection form of the Morcos cave. Actually, the Morcos cave is not inside of the cavernous sinus. That's lateral to the cavernous sinus. And the carotid artery is related to the Morcos cave. Leaving the Morcos cave, the trigeminal nerves divided in 3 branches: ophthalmic, maxillary, and mandibular branches. And it has 2 portions: the sensory root, the pars compacta, and the motor root. Usually, you can classify the trigeminal nerve into 3 segments: cisternal one, from the brainstem to the petrous apex; intracranial extradura, from Morcos cave to the foramina; and extracranial, that's V1, V2, and V3 portion. We can see here below the cavernous sinus, as Shekhar has shown. You can see the Morcos cave, you can see V1, and the nerves inside of the cavernous sinus, 60 nerve, and the branches of the cavernous side of the trigeminal nerve in a frontal lateral approach. Classification of the tumor extension. Why is it so important to classify these tumors? That's important to know how should you operate the case and to compare results. And several classification systems have been proposed in selecting the optimal surgical strategy of these tumors. Jefferson, 1953, divided these tumors into 4 groups, depending on the anatomic localization of these tumors. If the tumor is in the posterior fossa, the root type; if it's a combined posterior, middle fossa, dumbbell type; middle fossa, ganglion type; and peripheral division type. Sami, 1995, modified this classification into 4 categories based on radiological findings. Type A, intracranial tumors predominantly in the middle fossa. Type B, predominantly in the posterior fossa. Type C are those intracranial dumbbell-shaped tumors in the middle and posterior fossa. And type D, that's the extracranial tumors. One very new classification is by Vanipucci and all, in 4 anatomical categories also: peripheral, ganglion, root, and dumbbell tumors. Peripheral tumors are along the V1 in the orbit, V2 and the infratemporal fossa and maxilla, and V3 into the infratemporal fossa. And ganglion type is the middle cranial fossa. The root type is in cisternal segment of trigeminal nerve in the brainstem. In dumbbell involve the ganglion and the peripheral branches or the ganglion of the posterior fossa. We have our own classification. I have published it in 2008, and we divide these tumors according to the level of difficulty of the surgery. And we classify these tumors as type A if the tumor is predominantly extracranial with small middle fossa extension. Type B if the tumor is mostly in the intracranial middle fossa with some extracranial extension. Type C tumors are those in the middle fossa. Type D, those tumors in the posterior fossa. Type E, those tumors in the middle in the posterior fossa. And type F, those tumors with extracranial, middle, and posterior fossa extension. That's our case. You can see here, we had 4 cases type A, 5 cases type B. The most frequent type is type C, the middle fossa, 14 cases. Type D, 7 cases. Type E and 7 cases, and 2 cases of type F. How about the surgical approach for those tumors? We have numerous surgical approaches based on tumor category have been reported. And more recently, endoscopic endonasal transparagoid approach are also used and proposed to access the Meckel's cave. But due to the difference in the classification system, the small number of cases, lack of volumetric measure, size of the tumor, and posterior postoperative results, it's very difficult to analyze the results and the efficacy of these different approaches. And how about the surgical goals and the difficulties? Surgical goal is, that's in most cases, a benign tumor. It's total removal and preservation of the trigeminal nerve function. And the difficulties we have, if tumor size. If the tumor is a large one, it's much more difficult to remove. If this tumor is highly vascularized, if it's fibrous, it's adherent to the surrounding neurovascular structures. And you should be careful because it's very easy to produce cranial nerve injury, like the trigeminal nerve and its branch and other cranial nerves. Gross total removal of these tumors is in the literature about 83% of the case, with some complications rate about 1.9 to 8%. That's our service. We have treated so far 39 patients between 1991 and 2018. We have, as I said, operated more than 800 vestibular schwannomas in this period of time. The size of the tumors, most tumors are medium-sized, about 3 to 4 centimeters, but we had 7 giant tumors. The preoperative symptoms of this patient, trigeminal hypesthesia was the most frequent with facial pain, headaches, and hearing impairment, diplopia, and case with hemiparesis and increased intracranial pressure. We have published our results and our strategy in treating this tumor in some publication, but very important is to try to remove completely this lesion and preserve the trigeminal nerve fibers. I'd like to show you some examples. That's a type A tumor, you can see here. That's a tumor mainly extradural, it's a peripheral type. And in this case, we operate through a transmaxillary endoscopic approach with total removal of the tumor. This other case, you can see that's the same type, type A, that is some invasion of the middle fossa. You can see the dura of this, and it's a closer relationship to the internal carotid artery. I'd like to show you this video. You can see at first we prepare a nasoseptal flap to cover that portion of the middle fossa. You have to remove the tumor, you have to open the dura sometimes, and you can have a CS leak. Then you prepare nasoseptal flap, you can see here, and then a transmaxillary approach. And then you dissect the tumor, the endoscopy. You can see here the tumor. And here you can remove the tumor en bloc. It was important to cover this portion of the middle fossa that was infiltrated with this nasoseptal flap. You can see the pulsation of the internal carotid artery. We have to cover this region. And that's the way we operate. You can see the flap here, covering that portion of the middle fossa and cover the internal carotid artery. And fiber glue. And that's the way we like to operate these type A tumors. Type B tumors, usually you use a combined approach, an endoscopic transmaxillary and some middle fossa approach. If this tumor is large like this one, then you perform an extra intradural middle fossa approach. Type C tumor, we perform the extradural middle fossa approach. You can see here on the right an example. And I like to show this video. That's the position of the patient, the surgical incision with navigation. And then we dissect extradurally with the middle fossa, looking for the V2 and V3, and coagulate the middle artery, cutting the artery, meningeal artery, and then expose extradurally the tumor capsule. You can see here that's the tumor exposed extradurally. Then we make a debulking of the tumor, open the capsule,
Por favor,
make a debulking of the tumor, like a vestibular schwannoma, and try to identify fibers of the trigeminal nerve. You can see here fibers of the trigeminal nerve, and dissect from the tumor capsule. That end we remove completely the tumor and preserve the fibers of the trigeminal nerve. And then close the wound with a fascia to avoid CSF fistula. But some cases are larger and they have some extension to the posterior fossa. In this case, I would like to use the extra Intradura approach for large type C tumor. I'd like to show you this video. It's a larger tumor with a cystic component in the posterior fossa. The same procedure, extradural at first. Then you can see the tumor, that's a vein around the tumor capsule. You coagulate this vein and remove the tumor, trying to preserve the fibers of the trigeminal nerve. And that's the posterior fossa. There's a cyst in the posterior fossa and remove the tumor in the capsule. That's the middle fossa, that's the posterior fossa after a radical removal of the tumor. Then we have to cover all this defect. That's another case. You can see here also a cyst in the posterior fossa. The same procedure. Cutting the middle meningeal artery, and then you can see the tumor capsule, debulking. Always the goal is to try to preserve the fibers of the trigeminal nerve. The bulking of the tumor is very important. In this case, after removal of this portion of the tumor, we open the tentorium, open the dura, open the tentorium, and remove the tumor in the posterior fossa. And then close the wound. We are using the red sigmoid approach in type D tumors. You can see here, that's a large trigeminal schwannoma with a cystic portion. We could remove this tumor through the red sigmoid approach. In some cases, if the tumor has some extension to the middle fossa, we remove the suprameatal tubercle to remove the portion inside of the Menkes cave. That's how we do. After removal of the posterior fossa tumor, we open and remove the suprameatal tubercle to reach this portion in the middle fossa. That's the fifth nerve, 7 and 8. You can see here how we remove the tumor through these routes. And that's a case, you can see here, that's a large tumor. The tumor was operated before elsewhere. They did a biopsy of the tumor. You can see here the tumor is in the posterior fossa, in the middle fossa. And after this approach, we could remove completely this lesion. Type E tumor, we use the pre-sigmoid approach. That's how we do the pre-sigmoid approach, craniotomy, and expose the sigmoid sinus and the transverse sinus, open the dura, and then remove the lesion. You can see a case, that's the tumor. That's the middle fossa, the posterior fossa, ligating the petrosal sinus, superior petrosal sinus, and cutting the tentorium. Then we cut now the tentorium. Be careful with the fourth nerve, and then expose the tumor. You can see here the tumor capsule, the coagulation of the tumor capsule. Then we perform debulking. And always trying to see where the trigeminal fibers are and try to preserve some fibers of trigeminal nerve. Here you can see dissecting the capsule from the brainstem. You can see the basilar artery. And after complete removal, and then in this case, we have a large surgical defect. We close the dura, but to avoid CSF fistula, we have developed a technique of cranial-based reconstruction. We have published it in 2005 in neurosurgery. We like to use the third posterior portion of the temporal muscle. We are using also for jugular foramen tumors, and using the temporalis fascia and the cervical fascia to cover all the defect. You can see we rotated the temporal muscle and then cover all the defect with two vascularized planes. That's how we do it. That's the cervical face. That's the temporal muscle rotation. If you don't reach the surgical defect, you can make a back cut and then rotate it. Very important is to keep the vascularization of this flap like that. And then you can cover this portion of the defect and then rotating back this fascia in two vascularized planes. And the surgical, the cosmetic effect is very good. You can see here on the right. That's a case of a type A tumor. You can see here after pre-sigmoid approach, you could remove completely the lesion. And finally, type F tumor are those very large tumor with extracranial portion, middle fossa and posterior fossa. In this case, we usually combine approach to transmaxillary endoscopic approach and a middle fossa pre-sigmoid approach to remove the tumor. You can see this case 25 years after the surgery. The patient is quite good. Our results, total resection was possible in 36 cases, 92% of the patients. Near total resection in 3 patients. We had 2 cases of recurrence and no mortality. Reason for near total resection was adherence of the tumor to the cavernous sinus structures, especially in F2 patients. And one patient with ENF2 recorded 5 years after radical removal. And one patient with a malignant schwannoma recovered also after some years. 27 patients in our series developed semi-anesthesia and at least one branch of the trigeminal nerve. We are always trying to preserve the V1 ophthalmic branch of the trigeminal nerve to avoid corneal lesion. The trigeminal motor function was preserved in 25 patients. We had 2 CSF leaks were treated in the lumbar drainage. In 2 of 19 patients, preoperative facial pain remained symptomatic. That's a problem. How to treat this pain after surgery? Usually we try with Tegretol, with carbamazepine, but some patients need balloon occlusion or even other procedures. Two patients with preoperative hemiparesis present postoperative improvement. There was no mortality in this series. And how about radius surgery? If you see the series in radius surgery, you see that a tumor control can be achieved between 70 to 80 or 90% of the case. But the longer follow-up, probably this patient will have recurrence of the tumor, and then you have to operate. I think radiosurgery could be performed for elderly patients if you have a small remnant of the tumor. Our conclusion. Our results indicate that the most of the trigeminal schwannomas can be removed totally and safely during a single operation, regardless of the type of the tumor, using skull-based approaches. Preservation of trigeminal nerve function can be achieved even if you perform a total removal of trigeminal nerve. We should always try to preserve the ophthalmic branch of the trigeminal nerve. Larger studies are necessary to know the long-term result and complication of gamma knife or radiosurgery in treatment of this tumor. And the classification we have proposed 2008 allows better choice of surgical approach and anticipate the surgical difficulties. I think these tumors are very nice to remove because they usually are not so vascularized. You have a plane to dissect, and you can preserve with good microsurgical techniques, you can preserve the nerves. Thank you very much for your attention. Thank you very much, Jack, for the invitation.
Thank you, Ricardo, for this spectacular presentation on trigeminal schwannoma, a rare pathology, a very pleasant pathology, and thank you for putting it in such a didactic way for our audience to learn more about. So without further ado, I'd like Torsten to share his slide with us and present the case he had in mind and ask, unmute yourself, Torsten, and you know, you could ask whatever questions you want of the panelists, how they would handle the case, the speakers. It's your show. Go ahead. And welcome, and thank you for staying up so late. I'm really appreciative of that.
Thank you, Chuck, for the kind invitation. So I thought I'd discuss a case of cavernous sinus meningioma, and of course, pick the brains of the expert faculty that we do have here. Let's see.
Click on the slide itself with your mouse, and then you can advance.
So I just quickly looked at the evidence base. I like to do this, to do a quick PubMed search. If we put in meningiomas, we have 25,000 hits. If we limit it to cavernous sinus, you can see that it drops off quite quickly. But still the majority is from the neurosurgical literature, and the rest is from radiotherapy literature. This is the evolution over time, and we can of course see the
Have you advanced your slide? We're still at the title slide.
Oh, I have. Why haven't I?
Try again. And go next slide.
Now?
No, we're still on your title slide.
That's worrying.
It's okay. You can do it that way. We can see the slide. I'm not sure why. We can see the evidence base. Yeah, I see it. Yeah, we see it normal. Yeah.
Share, resume, share. You see this now?
It's still only PubMed, the PubMed box.
Really?
I don't know. That's a strange one. You can keep it in this format. We can see the whole slide here.
Okay. So I will. Okay. So I will do this then. So I'm not sure. I don't have the builds now. Okay. So you have this now. The next.
Yes. Yes.
Okay. So this is you can see the evolution over time, and this is the 80s, so the heydays, I guess, and then there was a drop off. And now we have more and more literature. In the recent years, of course, from the radiosurgery, radiotherapy literature, but also perhaps more and more endoscopic literature. We can agree that the treatment paradigms are typically like this for the cavernous sinus meningiomas. If they're asymptomatic, we tend not to touch them. We observe and treat if documented growth, or if they become symptomatic. And by treatment, we generally mean radiotherapy or surgery. What is important is to differentiate between the extracavernous and the intracavernous. And Dr. Sekhar alluded to the dural line. You can see this is the dura line here, where we have the nerves medial to the tumor if we come from a transcranial approach, whereas the intracavernous meningioma, of course, the nerves can be, or typically are, embedded in the tumor. I'd like to present this case, 48-year-old female patient, previously fit and well, presented with headaches and increasing facial pain and a short history of diplopia. This is a pre-op MRI, and we can see this will be the dural line, as Dr. Sekhar was alluding to. So what to do is this is more a typical case than the two extremes, namely there is an extra cavernous part and an intracavernous part. And the question I would like to discuss or have their opinion on is how aggressive we should be in a case like this.
Ricardo, oh, sorry, go ahead.
Sorry, yeah.
You want them to go ahead. Ricardo, how would you handle this? What cranial nerve palsy, Torsten, did you say the patient had? A sixth nerve?
So she had the diplopia. It was a sixth nerve, but she complained of double vision on lateral gaze.
Yes. What we do here in Curativo in these cases, we remove the extra portion or extra cavernous portion of the tumor, and very important is to decompress the optic nerve and the chiasm to give a radiosurgery, and you perform radiosurgery in gamma knife. But it's very important to decompress the chiasm and the optic nerve. What we do.
Ricardo, when you say decompressed, do you mean anterior clinoidectomy, or you mean only the intradural component of the tumor?
What I mean is we should have the nerve free. If there is tumor inside of the optic canal, you have to open the optic canal, but we need at least 2 or 3 millimeters from the tumor to the optic nerve with safe gamma knife radiotherapy. That's important. Usually what we do is we put a piece of fat between the optic nerve and the tumor, the remaining tumor, to before we perform the radiosurgery.
Sheikh, how would you handle this case?
Yeah, so this is a 43-year-old patient presenting predominantly with trigeminal pain syndrome. And what I would do here, and some diplopia, but it's not the major element. The trigeminal pain, I guess, has been present for 3 months. And presumably she's been on some Tegretol or some other gabapentin or something. What I would do here is do what Ricardo is suggesting, but a little bit more than that, to actually peel the lateral wall and decompress the trigeminal nerve in the cavernous sinus, and also remove any tumor inside the Meckel's cave. And that's, if you can go back to the axial view, I didn't see that part. And then I can't tell because the cuts are a little high, but it looks like there is some tumor in the Meckel's cave. And then send her for radiosurgery. I think that this approach seems to give the best of both worlds. you may be able to, if the tumor is soft, you may be able to remove, debulk, or decompress some of the tumor via a superior approach where you get very minimally into cranial nerves while you decompress the optic nerve. And I think that I agree that decompression of the optic nerve is also very crucial before you give the patient radiosurgery.
I'd like to make a comment also. We should know where the implantation of this tumor is. If the implantation is posterior, you can remove much more tumor. Usually I open the lateral wall of the cavernous sinus also. But if the implantation of the tumor is anterior, is in the fissure, the anterior fissure, then it's almost impossible to remove the tumor without damage of the nerves. I think the implantation of these meningiomas is very important.
But one more point here is that, you know, giving radiosurgery is not the end of the road. You have to, the patient has to be followed. For instance, there's a significant pituitary compression. And that's something that you may well be able to decompress from the superior approach, because medial to the carotid line, if you look at the cavernous carotid artery, we don't see that very well here, but if you look at the follow the carotid artery, anything medial to the carotid line is very safe. There's nothing other than the pituitary gland. Of course, this can also be accessed by an endoscopic transsphenoidal approach. But nevertheless, I think decompressing the pituitary gland will be, is an additional benefit of the kind of thing that I'm describing, which is a partial resection.
Okay, so it's pretty much in line with our thinking. This is a mix. I like to Dr. Sekhar alluded also to this in his slide. You know, the workup. So we skip this. I think crucial is to define surgical strategies, and I try to discipline myself to have a plan A and a plan B. So you think ahead. I prefer the neuromonitoring, not so much perhaps for the monitoring itself, but for the mapping. So i.e. to identify the tumor and to see the tumor, no, sorry, the cranial nerves, and to identify them before they identify me as a surgeon, to see through the tumor, so to speak. I tend to do extradural clinodectomy. Any comments on that?
I think no comment really. It's nice, but there are anatomical variations where the clinoid is particularly long. You have a middle clinoid process. You have very prominent posterior clinoid. In all those cases, you know, I don't think there's any reason to be dogmatic. You could do whatever is works out in that particular case.
Sheikh, but I agree with Torsten. It's so much cleaner to do it extradurally. I mean, you know, the barrier, the dura is a nice barrier. And I'll invite Teet Mathiesen, who published on this. If I could ask you, Teet, if you unmute yourself, remind us of your work many years ago about extradural clinodectomy prior to manipulating the tumor and visual outcome.
Yeah, we published on sort of pre-dissection decompression of the optic nerves, and found that the outcomes were much better if the optic nerve was decompressed already before we touched the tumor. This was maybe more relevant to tuberculum cella meningiomas, but I completely agree with you. I think it's usually very nice and clean to have the anterior clinoid out of the way and clean decompressed conditions when you open the dura.
So I agree that decompressing optic nerve is important, but again, I come back to the point. It purely depends on the length and the complexity of the clinoid. The other point is nowadays we also have the ultrasonic bone removal curette, sonopet, which also makes it very clean and elegant. You know, don't try to, there's no one way. And of course, this is more pertinent for vascular cases. I try to do intra-extradural clinodectomy, that is extradural as much as possible, stop, and then have both the dura opened and then have the control both intradurally and extradurally to avoid any damage. But I think that there is no dogma. Do what is the best situation in that patient. You know, if you're saying that clean means that there's no bone dust, just suck it out, have your assistant help you, etc.
No, I agree with you, Sheikh, and clearly you illustrate that the pupil knows the dogma and the master knows the exceptions. And what is most important here, I think, is to be aware of the anatomical variation that can cause havoc. One of them being the very aerated anterior clinoid. The other, of course, when there is a bone that stretches far posteriorly or even goes around and circulates the carotid. And if you start pulling such clinoid extradurally, you can certainly create some nasty bleeding from the carotid.
Torsten, why don't you continue?
Yeah. Yeah, so plan B, I tried to discipline myself. It's easy to fall in love with the cavernous sinus and surgery. And so I tend to open, and if the tumor is soft, and so two conditions, tumor soft, and I have a good nerve monitoring on 3, 4, 6, I will continue. If not, I tend to be very reluctant. This just the monitoring. We do, of course, the peeling, the Morcos type with the lateral view, and peeling off the cavernous sinus wall, as we've discussed already. Let me see if this will run. Is it running?
Yes, it's running.
So this is just the intra. We have done the clinoidectomy, and you can see. I would like to ask. Here we cut the draining vein from the Sylvian anterior into to get more access. So we've done the extradural clinoidectomy already. See the tumor is devascularized. I still like to resect the tumor separate from the dura. So I tend to do a tumor resection, and then decide how much dura I want to resect.
So Torsten, you don't do the Hakuba Dolling peeling. You just did the peeling enough to do a clinoidectomy, and then you go intradural. Is this how you like to do it?
Yeah.
Can I ask maybe Sean and then George? How do you do? Tell us your technical tips. How you do? I'm sorry. You know what? No, I shouldn't interrupt. No. Keep talking about your video when you finish.
Here I just chase. I use the stimulator to identify the third, of course, and then the movements along the oculomotor to remove tumor around the third. Lateral. This is, of course, but not opening the cavernous sinus along the dural sleeve of the oculomotor nerve. I would like to have their comments on how important this part is, say, for tumor control. Again, if the tumor is soft, it's a sitting duck, but if it's hard, perhaps you do more damage. Here you see down to Liljequist. This is optical carotid. No, sorry, the carotid oculomotor triangle. Peeling off soft tumor, posterior clinoid. Then we go lateral. Need to identify the trochlear, and again I use the stimulator just to verify the position. Probably more for the surgeon's nerves than the patient's cranial nerve, as you can see here. And then peel off the last parts of the intradural tumor. Here we see the brainstem. Yeah. So uneventful recovery. I removed I did the peeling afterwards of the cavernous sinus, over the trigeminal nerve, and she had significant improvement of her fifth. This is the post-op images, as you can see, and we've basically followed the line here. Pituitary not decompressed, that Dr. Sekhar was alluding to. I have some, let's see if does it still not work?
It only shows questions, the slide titled questions.
Why is that?
It's very strange.
And it's still question.
Nothing. Yeah, only you can see on your screen the text because it's very strange.
C'est bizarre. Okay. So
we see management, surgery, post.
Yeah, so it was the questions to your other faculty. You know, was it too aggressive? What do you tell them about the risk benefit? The information part we can discuss. Use of monitoring. We have shown to use neural navigation. Extradural we did discuss. Falciform ligament, you said decompression of the optic nerve, but if there's no meningioma around the optic nerve, do you always open the falciform ligament? I have let's say a theory that it might actually open up a barrier to the meningioma for the growth, and that we can actually do worse if there is no overt meningioma along the optic nerve. So unless I have meningioma at the ligament, falciform ligament, I tend to leave it closed. Dr. Ramina said the fat. I also tend to use fat to facilitate radiotherapy afterwards. Fossa posterior dissection in this case. Any comments?
Sean, could you unmute yourself? Just can you give some comments? How, at least how differently would you handle this case?
Sure, I definitely would have had the same surgical strategy. I think to the question earlier about the lateral cavernous sinus peeling, I do like doing that for these cases where you're trying to do an optimal subtotal resection of all the extra cavernous disease. I think, at least for me, the advantage is I can find, 3 and 4 early before I enter the cavernous sinus. For me, that's a little bit of an anatomical boundary that I find that. And then also opening up the oculomotor trigone so that, the proximal and distal aspects of the third nerve are identified. To the comment earlier about the clinoidectomy, I prefer the extradural clinoidectomy, but I'm not dogmatic about it. I think the advantage of that is you know where the optic nerve is early, and also the cavernous segment of the carotid artery. Those are the structures I sort of like to identify earlier on. So those are sort of some of the slight differences that I would have done.
George, if your goal in a case is cavernous sinus partial debulking and decompression, when do you do it endonasally? When do you do it transcranially?
Well, I think in a case, and I guess the third question is when do you do both? That may be on the aggressive side, but I guess the question of where the bulk of the tumor is and what do you think is compressed. So if someone has a 6th nerve palsy, there's a compression of the nerves usually within the cavernous sinus itself. And that's been shown to respond both from an endonasal decompression or from a lateral decompression. I do like to do, and that's something I learned from you very well, to peel the lateral wall of the cavernous sinus in the beginning. And as many great teachers, one of them being Dr. Ali Krish teaches, there's always a plane, and if you start from normal and go to the abnormal, you can always sort of extrapolate, and that's where the nerves will be. So in a way that makes it a little bit stupid free, so they can take everything lateral to that, and where the cavernous sinus is. Now, in terms of when to do an endonasal decompression, in a case like this, I think it's worth obtaining a pituitary panel. And if you find, for example, a little bit elevated prolactin, but even if you don't, if you're planning to radiate this tumor immediately after, I think it's worth, as Dr. Caldwell has taught us, to create the spacing that we talked about earlier for the optic nerve, to create it for the pituitary as well. And this is at least what I would do. You can do this surgery through either like a small lateral orbitotomy approach and combine it with an endonasal at the same setting, where you can have sort of the best of both worlds. And then you can see, as Dr. Tolstein was saying, if this is a soft tumor, you can proceed and do elevated debulking within the cavernous sinus. Actually, if it's a soft tumor, you may be more able to do some of the debulking from the endonasal standpoint, because you don't have the nerves in the way. In a young patient, I think it's worth trying it and not being too aggressive. And obviously, monitoring is going to be instrumental in being safe here. Just my naive and relatively inexperienced 2 cents.
Torsten, could you put back the slide of the schematic of the lateral wall cavernous sinus? And yeah, I'm going to use one question from the audience who's talking about Ali Krisht. Ali says, actually, he gave a talk here a few weeks ago, and he said the picture on the right is wrong, that it's in the textbooks, and that nerves are not like this embedded by the tumor. So I don't know. I know you spent time with Ali. Like, what do you think? You think this is a wrong schematic?
I think because if there's intracavernous, the nerves are pushed towards the dura, so they would still be at the periphery of this. Yeah.
It's true. That's how we find them. And I mean, this is how we conceive of them, but that's not really how they are. I agree with that.
If this line of the lateral cavernous sinus was along the nerves, I think that's, represents the truth, where you have a part that's lateral to the true lateral wall of the cavernous, and there's where the nerves are, and that's easily resectable in part that's medial.
Right. Right.
Well, obviously, the important thing is that you have a double layer of dura, which and the cavernous membrane contains most of the nerves, so which creates the line between the extra and intracavernous tumor.
I'd like to ask you about the implantation of the tumor, because in some cases, if you have the tumor implantation, the part of the cavernous sinus is much easier than the superior orbital fissure. I'd like to know your opinion if you have this case, because I had some case that was intracavernous meningiomas, but it could be removed because the implantation was in the posterior part of the cavernous sinus, no tumor in the superior orbital fissure.
Sorry, Ricardo. Who are you asking? Who are you asking?
Everybody. About this, the implantation of the tumor, if it's make a difference.
You mean the site of origin? Or
yes.
Yeah. Well, I mean, I find it very difficult to know when they're large exactly where they started. I don't know about the rest of you, but when they're small, of course, when they're large, I call them intracavernous. If they look hollow cavernous, I'm not sure how to make the differentiation.
Problem, we are seeing more and more patients with small tumors. And then is the question, what to do? Wait, or to go on and to remove the tumor, or what should you do?
Well, I'll go back to Teet. Well, no, actually, I'm not going to ask Teet the question because I saw his slides. He's going to cover. Anyway, I will keep it for Teet Mathiesen regarding that. Probably will cover some of it in his talk. Torsten, anything else you want to share or ask before I move to Teet?
No, well, no one addressed the question regarding let's say the resection of the posterior fossa, the infratentorial tumor parts.
Which one? I'm sorry. Which one was it?
Tumor, intradural tumor along or around the oculomotor or the infratentorial. Do you chase it or do you leave it for radio surgery?
I think you chase what you can get easily without creating more nerve injury. I'm not sure, again, that there is a dogma with that.
So I think actually, Jacques, you asked about dissection of separating the two dural layers. And,
that's what he's asking? Okay.
No, I mean, if you do that peeling,
yes,
and you all the way back to the tentorium, then you also have the nerves, and you can quite easily open the porus oculomotorius, decompress and mobilize the nerves, and then you have much more space to chase all intradural meningioma. So I would recommend doing that.
I agree. There was only one axial there, but it did look like the part that's in the posterior fossa might have been along Dorello's canal, and that's why the patient may have been having a sixth nerve palsy, which goes to what Dr. Ramina is saying, that maybe the origin is more posterior. You know, so again, the question is, you know, if you open that area, is there any worth for improvement of symptoms? But I don't know the answer to that.
Yeah. Okay, for the sake of time, I think I'm going to move on. And Tiet, I'm going to show your slides. I'm going to share. Torsten, thank you. Could you stop sharing? Perfect. Let me share Tiet's slides. You can see them? Yeah. You're muted, Tiet. Unmute yourself.
Sorry,
just
so
tell me next and I'll advance.
I'll do that. So this is pretty much a continuation of Torsten's talk, but a little bit more bread and butter. I don't think we need to doubt the surgical indication very much. And I think all already agreed that our primary objective is, if you go to the next, to remove the intradural tumor and not enter the cavernous sinus. Now, we were at this point, and I think all of you have mentioned radiosurgery, and I think Torsten said he liked to wait if it grows and treat later, and some other of you would go right away. Would you like to discuss I'd like to hear your strategies and why you select them.
Let's, Sheikh, can we ask you, when you have a residual post-op cavernous sinus meningioma, do you wait or do you gamma knife straight away?
How old is this patient?
No, I mean in general.
This patient is 43.
43, yeah. So no, one thing, what I was going to say, this is obviously what I call a spheno-cavernous meningioma, and you've done a really nice job here removing all extra cavernous tumor. In a 43-year-old person, I would try to peel the lateral wall and open up the Meckel's cave and decompress the trigeminal nerve, which you can see there, and remove some piece along the tentorium. The reason being, if you give radiation of some kind, I think that there's some swelling of the nerve, and the nerve is somewhat more at risk when it's compressed by the tumor, etc. So in regards to radiosurgery, I use a kind of a vague age cutoff line, and that is the vague age cutoff line is somewhere between 60 and 65. If they're below 60, I give them upfront radiosurgery. If they're above, then I wait and see if there's growth. And also I look at the WHO grading. If it's grade 2, almost certainly I'll give radiation or recommend radiation up front. If it's grade 1, I think, and if the patient is reliable for follow-up, you can follow them. That's my practice.
That makes sense. But on the other hand, there is a small problem. I don't think the recurrence rate, the actual recurrence rate differs very much between grade 1 and grade 2 residuals. The time to recurrence differs a lot. But on the other hand, the grade 2 tumor responds much worse to radiation and may even have a higher risk of becoming more aggressive after radiation. What do you think about that?
That's a controversial point. you know, really, there are some trials now ongoing with regard to grade 2 tumors, both completely resected and incompletely resected. You know, I think the jury is still out on that. Certainly, you risk making the patient worse with radiation.
Actually, December this year will that I forgot the name of that trial will be finished. So maybe we'll have some results.
Yeah.
Okay. Well, let's move.
Next, you want
let's
next
move
slide?
next. Yes, maybe even. Let's move even to the next after that. So I think the two rationales are either many people cite Sandhu's paper where we had a long-term follow-up of cavernous sinus meningioma residuals and had a very low number of regrowth. And our data on meningiomas engaging the cavernous sinus, this was based on 49 patients, which was some years ago, but we had, looking at the 8-year control rate, just from a Simpson grade 3 removal, which is sort of, I think, best of what one can get in the cavernous sinus, we had a fairly good control rate. Then we had what we call a Simpson grade 4 gamma. That's, we make a subtotal resection, but we treat the residual right away. So we call it a Simpson grade 4 gamma to denote that the entire tumor has been treated, some with microsurgery and some with radiosurgery. Then we had an 8-year control rate of 92%. When we only did a Simpson grade 4 and then followed with a wait and scan approach, 18 patients, then during rescanning, 16 of those progressed. So just the grade 4 had an 11% control rate. If we factored in that when they progressed, they were treated by radiosurgery, and then it's no longer the 8-year control rate, then it's 2 to 5-year control rate after radiosurgery. For those 16 patients, we would have a 69 control rate. So the actual strategy of a wait and scan and then radiosurgery would have a 72% control rate compared to the upfront radiation with gamma. So I think we had nice figures to support upfront radiosurgery.
Tit, remind us, what are the sources of selection bias in your study? Could there be, for example, volume of residual tumor in one group versus the other? You know what I'm saying?
Yeah, of course. Well, that's an obvious selection bias. I went through the cases, and I don't think that explains it. What really was the selection bias that we didn't know. So sometimes we treated, and sometimes we thought that we did good surgery, and I mean, it would not grow. It's in the cavernous sinus. So it's pretty much random selection here. But of course, you need a prospective study to be able to tell. And anyway, that was the rationale, and the rationale we followed. But the case is not over yet. Let's move next and next after that. So, well, the patient had Simpson grade 4 gamma and had radiation, and also this piece of fat that was already discussed by Ricardo. Let's move to the next. I think it's necessary to have long-term follow-up of patients. So we did this very successful radiosurgery, but this is 9 years down the road. It is a little bit larger now, is it not?
Quite a bit.
So now what do you do? And now he has affection of 3, 5, and 6 also. Now what to do?
Was that growth gradual, or did it speed up the last year?
It sped up the last year.
Ricardo, oh, sorry, Sheikh, go ahead.
No, I just want to ask, how old is the patient?
The same guy, the 45. Oh.
Well, now he's 52, but he used to be 43.
And he has complete paralysis?
No, not complete. I mean, he has symptoms from all of these nerves. 6 is probably complete, but 3 is partial and 5 is partial.
Yeah. Well, I think that, the tumor is acting in a very aggressive fashion at this time. What I would do in a case is, as I showed earlier, carotid artery, definitely carotid artery bypass. Once you bypass the artery, then you're just dealing with the cranial nerves. I think most of the patients, you can preserve cranial nerve 3 because it has a very short course inside the sinus. You know, unless there's a lot of tumor growth around there, we don't see a coronal view. But most of the time you can decompress the optic nerve and preserve third nerve. What's the value of that? You know, the patient is happy to have an eyelid which is non-ptotic. It'd be very difficult to preserve 6, 4, or even 5 in a case like this, especially after previous radiation. So the patient has to be prepared for that. The other question is, you know, is tumor tissue banking and looking at various antigens. Is this patient a candidate for any kind of protocol? Those are all things to be, you know, considered. If you do aggressive surgery, of course, you have to reconstruct the medial aspect so that there's no CSF leak. That's very important.
So when doing this surgery, I mean, we've discussed a few things, but of course, some patients have a very bad outcome, and some patients even die from cavernous sinus meningioma surgery. What is your experience that they die of? What kind of anatomical things can ambush you that give you a worse outcome than you expected you would have? What's your experience?
The good news is that, as I showed earlier, at least in the last 15 years, no one has died of surgery within the cavernous sinus, including, you know, various carotid arteries and things like that. I think the two things that can ambush you, actually there are 3. One, of course, is the carotid artery. So you should be a very good bypass surgeon with good experience. If you're not, then, you know, enlist your vascular colleague who can. But even in such cases, there are potential for problems. The second, and I think the more important issue, is infection. You know, CSF leakage and infection to me is the most dreaded, and that is slightly unpredictable in some patients. We do have to take maximal care with reconstruction, etc. And patients with long operations, we actually dose the antibiotics twice. And we also give double antibiotics, not just cephalosporin, but also cephalosporin, gentamicin, or gram-negative, because there are some gram-negative bugs lurking in our hospitals. So that's important. The last thing, which is unexpected, which we discovered in some patients, is vasospasm, especially if you have a lot of spillage of blood. Watch out for vasospasm, because this can happen, you know, 6-7 days later. So that could be an issue as well.
Yeah, I was going to ask about vasospasm.
I have actually couple of patients I had in my presentation I didn't show, but yeah, we have had a couple of cases where there was unexplained, you know, a patient was deteriorating, everybody thinking, well, maybe it's hydrocephalus, maybe it's low sodium, maybe this, maybe that, you know, and then so, well, hey, let's get a CTA, and that, well, lo and behold, there's some vasospasm. So I think that that's something we need to keep in mind. We just don't think of it in regards to tumors. You know, we think of it with aneurysms all the time, but we just need to keep that in mind as well.
Has any of you a habit of giving nimodipine before surgery to patients like this?
I've never seen vasospasm with this, the specific tumors. I've seen it with some bloody chondrosarcomas and things like that. No, I don't.
Okay. Well, I've seen in a couple of patients with large meningiomas with cavernous sinus engagement. So I tend to give that. There is a fourth ambush, which I think our Japanese colleagues talk a lot about. That's the venous system. Do you feel there is anything you would like to know about the venous system before entering into cavernous sinus surgery?
Well, I think the venous system is always important. I think we do an angiogram in patients with large tumors. So most of the time, the anteriorly draining veins are gone, but you should not take the venous drainage that's already established, you know, and deprive the patient of the existing venous system. I think that certainly More problematic, of course, with posterior circulation or posterior fossa tumors, as opposed to middle fossa or cavernous sinus. But yeah, I think it's very important. Venous system is extremely important.
Are there any specific variations that you look out for?
Well, in a case like this, the anterior drainage is gone. So the veins of the temporal lobe, they have to go somewhere.
Yeah.
So they may have rerouted into the, the middle fossa or the sigmoid transverse junction or the superior petrosal sinus. So all of those things, you should recognize. I think it's nice to do an angiogram and look at it, or you may be able to see it in a CTV or something, MRV, and you should develop your strategy to avoid such venous issues, definitely.
The other thing, Tit, along this line, I remember distinctly a patient where I was approaching, not exactly like this one, but a meningioma in the cavernous sinus region, and I used Eviseal, tissue sealant. I must have been too aggressive, and I must have filled more venous compartment than I wanted to, and the brain within few minutes started the hemorrhagic venous infarction. I backed out. She had a venous infarct. I came back like 6 or 8 weeks later and did the surgery. So certainly with the use of powder gel foam, tissue sealant, which has been now the common practice with cavernous sinus bleeding, we have to be careful not to overdo it. Reminds me of what Vinko Dolink used to say when he used to do it in the 80s, like put the Surgicel, but make sure it still bleeds a little bit, not so much that you occlude all the venous flow.
Yeah, I also have a bad experience of, but that was Tissile injection into the cavernous sinus, which resulted in a huge ocular venous infarct.
Huh? Yeah, I can see that easily.
I haven't published it, but
so I think it's a good idea to put it in small aliquots, and what Jock said was very important. Slow down the blood bleeding before you put something in. And the powdered gel foam is better than the liquid embolic agent, namely the fibrin glue or the Tissile. Powdered gel foam is a little more solid, so it doesn't penetrate so far. It doesn't give you the same degree, but it's not likely to go into the transverse sinus or something like that. Yeah.
I agree with you, Sheikh, and it wasn't actually I who pushed the needle. I told my resident not to be shy, push, and then he wasn't shy, and that's what happened. But well, let's have the next. So we removed the tumor. We were thinking of doing some more extensive vascular work, but we opened the tumor was so soft, so we did a almost complete removal of the tumor that you saw in 1 or 2 hours or something like that. And then we were happy. Patient was sent home and came back a year and a half later with
what
with
was it? WHO grade 1 or
it was still grade 1. It was grade 1 throughout the history, but the first WHO grade 1 tumor had proliferation index, Ki-67 proliferation index of 5, which is a bit high, and we checked progesterone receptor expression, which was absent, but it was a grade 1. Now with maybe more modern grading, SAM grading or something like that, we would maybe find something. But this was I think a rapidly recurring, fairly avascular, very soft meningioma, and we removed it a couple of times, and patient was happy. He kept his third nerve function throughout, and he had some sensation of the face, didn't have any bad trigeminal symptoms. 6 was gone and 4 was gone. And so in the end, when he started to have recurrences every 6 months, we thought it was getting ridiculous. He was sent again for a fractionate radiation, which stopped recurrences for 2.5 years. And when we know because he did a MRI follow-up in his referring hospital 2.5 years after the last radiation. But unfortunately, just after the session where he was shown to be free of tumor, his carotid burst and he died on his way out to the hospital.
You mean epistaxis?
Yes.
Wow.
Well,
It was a dramatic case, but I think it illustrates several issues and the chronic nature of these tumors.
I've seen a couple of carotid ruptures in malignant tumors, not with benign, but I think post-radiation meningioma probably is an aggressive tumor as well. So we had one recently where patient had coiling and so on and so forth, and almost died twice, but we salvaged the patient with some urgent bypass and so forth. But I think that that's a real consideration.
So I have one last question. What is your view on what, obviously, almost all these patients survive nowadays, but many of them do not have a very good quality of life. What kind of deficit is it that affects their quality of life? And what about trigeminal function there?
I think that trigeminal pain is very difficult for patients, you know, and some people have dysesthetic pain. That's very difficult. A lot depends in regards to the other things, how much they can adjust to unilateral vision. I have one patient recently I took care of. He was operated 20 years ago by another surgeon for a chondrosarcoma, and he had almost no eye after that. But then he started to lose vision in the other eye. He came back to me and we operated, and then he had a prolonged course. He also had vasospasm, but he recovered completely. But the guy works in construction. You know, he does climbs up on ladders and goes on trees and does all sorts of things. He has to work. So I think to some extent, it also is a desire of the patient. You know, do they want to work or not want to work? You know, some of our patients, they have no other recourse, or they feel very positive, and other people, and I have some very beautiful young ladies, they have a little bit of headache and they are disabled. You know, we all have these patients. But I think that pain maybe, and then also diplopia, adjusting to diplopia, these are probably the two worst things, you know, for all of our patients.
Okay.
What is your...
Okay, thank you very much. Thank you.
Sean, go ahead. Unmute yourself and share your case.
See my slides?
Yes.
All right. Well, thanks for including me.
Your voice is low. We can hear you, but it's not high enough. You get closer, maybe.
About this, is this better?
Ah, much better.
Okay. Well, thanks for including me in the session. I'm gonna be great to get everybody's thoughts on this case. So this is a 33-year-old who had presented to me with a conventional grade 2 chondrosarcoma. You know, before presenting to me, she had had 2 previous endoscopic transclival approaches, had a previous transbasal approach, and I don't have the initial diagnosis scans here, but this started out as a petroclival chondrosarcoma. And so with each one of these resections, they were all subtotal resections, and there was always high volume disease left around the petroclival synchondrosis. With her transbasal approach, she then had proton therapy, and then presented to me 2 years after completion of proton therapy with significant disease progression. And so certainly on the coronal MRI scan, you can see disease within the cavernous sinus, extending down into the infratemporal fossa. The axials certainly show the extent of disease involvement of the petrous apex, the pterygoid plates, down into the posterior nasopharynx also, and a little bit into the parapharyngeal space. And you can appreciate certainly the mastoid effusions too, from the conductive or the eustachian tube dysfunction. And you know, on exam, when she presented to me, she had right-sided sort of complete 6th nerve palsy that was long-standing, and trigeminal neuropathy and conductive hearing loss. So, you know, certainly based on those scans, just curious to get the panelists' thoughts in terms of, you know, for a lady like this who's had 3 operations and proton therapy, would you offer surgery? and then if you offered surgery, what that surgical strategy would be.
Dr. Ramina, if you unmute yourself.
Yes, that's a very difficult case. But what we can do, should operate again this patient. Probably, I like to see the angiography of this patient, of this case, and probably we have to perform a bypass and then remove as far possible, as much as possible, this tumor. And because she was operated many times, and that proton therapy, I think chemotherapy is not working, is not, can make some trials in chemotherapy, but I think the only solution here is to operate again and probably see the carotid artery and make a bypass.
How would you approach it, Ricardo?
Transpetral approach.
You mean posterior petrosal or which anterior petrosal or?
Perhaps total petrosectomy and try to remove as much as possible the tumor.
Sheikh, how would you?
Yeah, I think that this woman is 33-year-old. I presume that the tumor continues to grow. And I think at this point, you have to be a go big or go home. And how do you go big? First of all, I think the patient has to be prepared for some level of morbidity and risk. I think this is very important to emphasize to both the patient and the family. And my operative strategy would be similar to Ricardo, but a little bit different. I would do a bypass. I haven't seen the angiogram here, but I would do a bypass. But in a case like this, I would run the bypass behind the ear. It looks like she's had something, she had some kind of posterior approach, I can't tell. But I'd run the bypass behind the ear and into the sylvian fissure. The reason for that is that I want to avoid the infratemporal space. And then in a second stage, remove the tumor and then have our plastic surgery colleagues put in a free flap. Because this one, once you get the tumor out, you're going to be left with a big hole. She may end up needing a third endoscopic stage as well, because some of the tumor, I suspect, goes quite low. I can't see the whole tumor on the coronal views. Yeah, there you go.
It goes low down to the longest musculature in the craniocervical junction in the midline.
Yeah, I think that she may need an endoscopic approach as a third stage, but it'll be nice to isolate the intracranial compartment so that the endoscopic surgeon, it'll be a transmaxillary approach. Then you can go through that and try to get it out. I think the goal, if you are going to offer this patient, I think this should be to try to remove this completely. I don't know that there's any other, and if you do have a small remnant, I think that she may still be qualified for some type of radiation. I don't know. The question is, what is the tumor here and what is just
No, we know it's a chondrosarcoma, he said.
No. The question is what parts are tumor and what is just aerated air cells and so on. I mean, you need to know where does the tumor stop and where does it transition into normal bone or and so forth. That's what I'm getting at. I mean, you really need to get it, be very aggressive. But she's a 33-year-old woman. I would try to offer her something if there's good understanding on her part as to what's involved. This is not going to be a cakewalk either for the surgeon or for the patient. I've had a few cases like this, adenoid cystic carcinoma and low-grade tumors, and they do okay, but sometimes the families, the patient, the families, they don't understand what they're in for,
Sean, why don't you keep going just for the sake of time?
So several great points. So, in terms of whether or not to offer surgery, just because of the practice here at MD Anderson with the Proton Center, I see a lot of patients that have failed proton therapy. And as I'm getting older into my practice, I'm seeing my own recurrences come back. And so you often wonder, whether or not to offer a big operation for some of these patients. And so we've looked at our own experience, looking at all the bony sarcomas, and the chondrosarcomas certainly behave across a spectrum. The conventional subtype tumors tend to be a little bit more indolent, And what we find is that with the grade 1 and grade 2 conventional subtype chondrosarcomas, even if they have failed previous radiation therapy, the ability to offer a salvage surgery where you can get a meaningful resection actually does have a significant impact on their long-term tumor control rates. And just as important as surgery is reirradiation therapy for these patients, and that's what we find. Luckily, proton therapy has evolved, and so has reirradiation techniques because of conformality. And we've looked at our own recurrent chordoma series, and the ability to offer repeat radiation therapy has a significant impact. And we've translated this to, these recurrent chondrosarcomas that have failed proton therapy. So I did offer her surgery. I've seen several of these chondrosarcomas progress in grade to become dedifferentiated chondrosarcomas. So with treatment planning, I did a biopsy first, just because imaging-wise, this looked much more aggressive, and this was still a conventional grade 2 chondrosarcoma. With these previously radiated tumors, get an angiogram, and she passed her balloon test occlusion. She had great cross-filling from her ACOM and her PCOM. When I looked at this just in my hands, I thought that there's extensive bony skull base involvement of the entire clivus crossing midline going towards the contralateral carotid. Certainly the petrous apex was involved and the pterygoid plates were involved. And the way I think about these tumors is the different soft tissue extensions, and of course relevant to the talk today is cavernous sinus involvement. And also the issue here, of course, were no local or regional flaps. All our pericranial flap, temporalis muscle, everything was gone. So I decided to do a hybrid approach. I felt that even if I did, for example, a fish C approach, I would have a hard time drilling out the midline clivus. I would have a hard time drilling out the lower craniocervical junction. I felt that if I did purely an endoscopic transparagoid approach, I would have a hard time getting out towards the middle fossa disease. So I decided to do both. I started out with an endoscopic transparagoid approach, and here, V2 is being skeletonized within the skull base, and the pterygoid plates are being drilled out. I'll skip ahead a little bit here. The carotid artery, skeletonizing the cavernous and the periclival segments of the carotid artery, and sort of fully unroofing that carotid artery, and then untethering it. Here I am injecting Tisteel into the medial cavernous sinus. And usually with any of these tumors around the carotid artery, I don't like leaving a bony shelf. I like having fully exposed. And then here I am opening the cavernous sinus lateral to the carotid artery. And then you can see a hint of the sixth nerve here that's pushed ventral to the tumor. She, of course, already had a complete sixth nerve palsy, but I sort of kept this as long as possible for the dissection. And then basically, I worked on dissecting the medial aspect of the tumor from the posterior wall of the carotid artery. And fortunately, there was a reasonable plane there. And then basically entering the tumor itself within the cavernous sinus and debulking it. And most of this was soft. There were parts that were pretty calcified where I had to use the ultrasonic aspirator. And then, as I was working, what I realized, I didn't have good access to the lateral cavernous sinus. Let's sort of pause there for a second. And so what I did is I extended my dural incision along V2 and up along the superiorbital fissure, just so I could identify 3 and 4 within the superiorbital fissure more anteriorly. And then, of course, resecting all the dural disease posteriorly along the brainstem. Previously radiated case, it's all basically sharp dissection, with a case like this. And then otherwise, endoscopically, what I did was drilled out the clivus, resected the posterior fossa disease and all the soft tissue extensions inferiorly. And then in order to drill out that petroclival synchondrosis, since she already had a conductive hearing loss, I sacrificed the cartilaginous portion of the eustachian tube. And on this image on the right here, you can see, basically I drilled out the petroclival synchondrosis. Here's the hypoglossal canal, skeletonized the occipital condyle below the hypoglossal canal, and basically drilled out all this bone back to dura and a little bit of the petrous apex. And then at this point, did a subtemporal infratemporal fossa approach. And so the retractor here is underneath the temporal lobe. The sucker here is on the orbital apex. You can see V2, V3, and basically drilled out the anteromedial, anterolateral triangles, Glasscock, Kawasis. I kept the glenoid fossa intact because the temporomandibular joint was not involved. What's not shown on the image here is the carotid artery I had looped and sort of displaced posteriorly. And then as Dr. Sekhar discussed earlier, the reconstruction was the issue here. And so we did a vastus lateralis flap that was plugged into the STA. And that was tunneled basically in the defect where I drilled out Glasscock's and Kawasi's to cover that petroclival defect. And so you can see the preoperative images here. On the post-op scans, of course, you see the anterolateral thigh flap, placed in that subtemporal tunnel. With regards to the extent of resection of the cavernous sinus, you can see preoperatively a lot of the tumor within the cavernous sinus was not enhancing. The capsule was enhancing, and that's what I ended up leaving behind was within the cavernous sinus, that enhancing capsule, because I just could not get it off those nerves with sharp dissection endoscopically. Post-op, she had stable deficits, discharge post-op day 5. And then she was a candidate for repeat radiation therapy, despite having the proton therapy, and basically was fractionated XRT to this cavernous sinus disease. And, especially with a case like this, we are also looked for our PD-1 expression and put her on a checkpoint inhibitor, again, just because of such a recalcitrant tumor. Certainly, at my stage of my career, there's certainly a lot of lessons I learned from these cases that have, these previously radiated bony sarcomas with regards to, carotid artery management when you're dealing within the cavernous sinus. For me, I like both the open and endoscopic approaches. And so I like the ability that if I feel like I'm pushing one approach too far, I want to be able to ensure that I can drill out the entire bony skull base widely. And so using multiple approaches that won't expose the patient to additional morbidity. And of course, a case like this highlights, the reconstruction challenges for such an unusual dural defect. And I guess I'm sure several discussion points, for the panel, but, as I look back at this case, and this lady is now 4 years out from the resection I did with no evidence of progression, but I still left residual disease within the cavernous sinus. And in this case, I relied on the endoscopic approach to really resect that cavernous sinus compartment. And, how I could have done better to resect more. And also, to enhance that resection, do you all think that I should have relied more on a lateral approach, like the lens approach, to resect that disease along the lateral cavernous sinus compartments? Those are sort of the thoughts I would love to, hear your opinions on. I think you're on mute, Jacques.
Sorry, you're right. Ricardo, do you have any criticisms of what he's done? Could you answer some of his questions?
I think such cases are thin cases, and you have to try to remove as much as possible the tumor, and perhaps if some remnant give radius surgery. But you can use multiple approach. I think endoscopic approach is very good. The problem is if the patient was irradiated before, in some cases you have scar tissue, it's hard, it's difficult to dissect the nerves. And I believe it's always much better if you go to a new approach, a different approach. But in such a large case, you have to remove. And the results were quite good. 4 years after the surgery, she's done well, and I think it's okay. It's very good.
Sean, I think regarding your question of maximizing the open approach, you had a beautiful view of the trigeminal nerves. Yeah, your chance was there. You've done all you can, and you had to leave some tumor on the nerve. I'm not sure that there is any criticism there. Sheikh, anything to add?
It wasn't clear to me if the carotid artery is open in the cavernous sinus or is it closed. I couldn't tell from your presentation.
It was open, Dr. Shekhar.
Okay, all right.
It was open.
I think you did a great job. I always try to go for maximal resection in a case like this, but submaximal resection where the patient is doing well is equally good. The important thing here, as you have emphasized, is the reconstruction. That's really what keeps the patient alive. And also the carotid artery, those two things are very important for this patient. If she were to recur, I would definitely, do some type of bypass because the carotid artery radiated twice is not going to do well. I think it's a case like this is very critical to have a very well-developed team in your hospital. We haven't talked about this much, team approach where you have ENT, neurosurgery, plastic surgery, but all under the guidance of one surgeon, that is the neurosurgeon, because you are going to call the shots, because any complication is a neurosurgical complication. All the other people disappear, you know. So you need to develop a plan. They need to be in agreement. And here, I mean, obviously in your place you do, but for some of the people that are listening in to this seminar, I would emphasize that a case like this is not one to be dealt with in a place with less experience, not having a team approach, and not having you know, various modalities there.
Sean, anything else you want to add to this or ask? Look, I think you did a fantastic job.
I appreciate it. Thank you.
Okay, George, unmute yourself.
One question, Sean, do you, obviously this is you did a fantastic job with this, and, you know, an open approach or like a free flap may have been required for reconstruction, but is the contralateral transmaxillary approach something that you use a lot for chondrosarcomas, or that you, is something, for example, I think that you could have maximized what you could have done intranasally with that, although, you know, it was so extensive, it's possible, very possible that you couldn't achieve the same outcome with what you did, which ultimately was very, very successful.
No, definitely since this case, I have been using the you know, the contralateral transmaxillary approach more for the cavernous sinus disease, and definitely has helped more with the visualization. You're absolutely right.
All right. Can you see my my screen?
Yes, it shows case 1. Yes.
Okay, perfect. So this is a little bit of a curveball in that it's not a case that directly involves the cavernous sinus per se, but depending what you think, it may be relevant to it. So this is a 34-year-old man, had multiple cavernous malformations, had actually underwent surgery before, and he presented with essentially a progressive third nerve palsy, which became complete and headaches, and had this scan. There was a little bit of a diagnostic dilemma what this was, but given his history, we're convinced that this was, again, a cavernous malformation. A little bit more detail. I wanted to make sure that this wasn't some sort of an aneurysm in that area. And we got a little bit more detailed imaging. You see this, the CISS imaging, which if you look closely, the solid components of this lesion are kind of just medial to the cerebral peduncle. And if you look on the sagittal image, the PCA is coursing in front of it, and there's a large part of it that's superior to the PCA. Also, a CTA showed that this had, the patient had a pretty tall posterior clinoid process. We also did fiber tracking, and it did look like the third nerve was sort of inferiorly and laterally pushed, and the corticospinal tracts were posteriorly displaced. You could see you could trace the third nerve on the KISS sequences, but this is an image that helps you understand a little bit better where it might have been. So I guess the question is, firstly, what do you do? Do you offer anything? Is an intervention even indicated? And in someone like this, the patient had been on some steroids with no improvement. And again, it looked like potentially he had kind of a progressive course with some recurrent events leading to that. And if yes, what would you do?
Torsten, just so we can help you stay awake, tell us if you'd operate and what approach you would use, and unmute yourself. And Teet Mathiesen, tell us, please, well, you can tell us whatever you want, but particularly, does radiosurgery work on brainstem cavernomas based on the Swedish and other European experience? So those, and then the rest of the panel can, of course, say whatever they want. Torsten.
Yes, as far as understood, he was symptomatic and had no, he had several episodes and did not respond to steroids. So I, given that I understood that correctly, I would
Yes,
offer.
patient is symptomatic
That
and
is correct.
yeah.
In terms of approach, I would probably
You want the MRI again to see?
Yeah.
Or-
I guess these are the two most relevant
Yeah.
pictures, I think.
So I would it's probably pointing enough laterally so you could go IPSI, or I would consider, with all the images, perhaps I even would consider going contralaterally.
Why would you do that? Why would you do that, Torsten? Since on that image on the left, the cavernoma is pointing to its own side. I know what you mean. We've
No, so perhaps with the angle, but my a priori I would say IPSI and not contra.
And Transylvian or subtemporal or what?
No, Transylvian.
Okay.
Mini trigonal, I think, and yeah.
Dr. Zenonos is pointing to us the level of the clinoid and the arteries. Are you concerned about the rostrocaudal extent of the lesion regarding your ability to expose it Transylvian?
No, not really. I would perhaps hedge it for a half and half, but no, I think we could go down there with coming from above. And if needed, you can shave off the tip of the PCA. You don't need many millimeters to get down there.
Teat, would you operate and also gamma knife for brainstem cavernomas? Unmute yourself. You're muted. Yeah.
Now I'm unmuted. So, I mean, this is a little bit difficult case because although slightly progressive, he didn't have very much symptoms as I understand. So, but certainly surgery is an option. And if the patient would want it, I would operate. The issue of cavernous
gamma knife.
Gamma knife is your question was, does it work? Well, depends on what you want it to do. I mean, we have tremendous.
To stop future rebleeding. That's what I'd like.
So we have tremendous literature showing that if you have a 30 to 40% annual bleeding risk before radiosurgery, and then treat the cohort with radiosurgery, the same cohort will have sort of 2 to 7% annual bleeding risk after treatment. Then again, there are no prospective comparative studies. So you only have studies with an enormous selection bias where pre-treatment bleeding risks have been assessed with statistical tools, then patients have been treated, and then their post follow-up bleeding risks have been again assessed. And it really doesn't make sense to say that the radiosurgery has had any effect on bleeding there. That we just don't have any data.
Okay.
So I think your guess is as good as mine. In my world, sort of a 2 to 7% annual bleeding risk is the background bleeding risk of cavernomas, and which is what people usually show after radiation.
Right. Sheikh, I'm going to presume you're going to operate. If how would you do it?
Yeah, I think that no matter what you do, you have to prepare the patient for a risk, which is third nerve palsy, because no matter what you do, most likely it will be temporary or partial, but I think the patient should know that that's a distinct risk.
Dr. Sekhar, the patient had a complete third.
The patient already has a complete third?
Yeah. He already has a complete third. It's not improving. Has no steroids.
All right. Well, I think that makes it a little easier, obviously, but still, I'd like to see if we can regain third nerve function. Would be nice. But if she's had a complete third for some time, it's not likely to come back. This is one that can be nicely approached by what I call the extended transsylvian, which is transsylvian with an full orbital osteotomy, anterior and posterior clinoidectomy. Why that is important is that you can see the solid part of the cavernoma a little bit better, and you have that, you show it pointing to the posterior clinoid process. I think it'll be nice to get that out. I think this is a lesion I've operated some like this in this location. You can get it out nicely by that approach. The contralateral approach was discussed, but not applicable in this case. It's pointing ipsilaterally. The lesion has made a path for you. And it's important to note where is the solid component. But in a case like this, if you don't see the obvious cavernoma, it may be important to try to get the capsule out. A lot of people leave the capsule in brainstem cavernomas, but that depends on whether you can see the actual cavernoma once you open up. That's an important point to remember.
Sheikh, why not a simple subtemporal Charles Drake's approach, since it's
I think it's a little bit high. The upper part of the lesion is a little high, and I don't know if there is something there or not. I don't think you'll have a full view of that by a subtemporal. I mean, if you assume that the cavernoma is all low down and you don't see a coronal view, then it's fine. But if there's some element of the cavernoma high up, then you don't have a good view via a subtemporal approach.
Ricardo, anything to add to the discussion?
In my first line, I would like to consider the subtemporal approach and open the tentorium. But I like to see the veins in the middle fossa. And then the second approach is the transsylvian approach. But I think that's the right side. And I think I could get to this lesion with this subtemporal approach.
Sean, you're muted. What would you do?
With the third nerve lateral, I actually would think about doing an endoscopic endonasal approach. I think
you're muted. Oh,
Can you hear me?
Yeah. Yes.
I think with the third nerve lateral to this, I would actually consider an endoscopic endonasal approach. By drilling out the tuberculum cell and taking out the posterior clinoid, I think you'd be looking directly at this when you open up the dura. You certainly would have to do a pituitary hemitransposition to expose this. But I would consider that sort of my first choice.
And you think that's a worthwhile endeavor when there is a very simple craniotomy that doesn't disrupt?
True. I guess I guess I was mainly considering the third nerve as the main thing here, with an effort to ideally protect it. Craniotomy would be much simpler.
Yeah. Okay. George, just for the sake of time, tell us what you're thinking, what you've done.
Well, so real quick, the subtemporal was the one that made a lot of sense. Nonetheless, I thought like the cerebral peduncle was kind of sort of in the way, and I would be having difficulty looking back sort of in the depth here, which was where I thought the solid components were based on the imaging. So that's the main reason kind of swayed away from that. An ipsilateral sort of cavernous with a posterior clinoidectomy was an option, but it had like that superior to inferior trajectory. And so I couldn't probably visualize things up here well. Going contralateral again was discussed, but it's sort of this is on this side and this artery is in the way. Another issue is that obviously you would have to work above the perforators if you went transsylvian, transcavernous here, and again you would have to do a posterior clinoidectomy. Well, before saying all this, I have to say that this was not a simple decision. Obviously, the patient had a third nerve palsy, was progressive, had multiple discussions with him, and his wish was to do something that would maximize the chances that this would have gone better. but obviously we had multiple discussions before deciding to do anything. And ultimately, sort of, I thought kind of like Sean did in terms of, I thought that the straighter shot tooth is where I could have the best visualization back here and have like an inferior to superior trajectory was an endonasal approach. As Sean said, with the hemitransposition, it's essentially a transcavernous approach to these lesions. And this is sort of the approach. It was very non-aerated. So we removed I removed the middle clinoid on each side, exposed the tuberculum, and then exposed a little bit of the middle clivus, opened the cavernous sinus on each side, and divided the inferior hypophyseal arteries, divided the ligaments there, exposed this tall clinoid, either the cortico-clinoidal ligament, and did the same thing on the other side. Again, here packing the cavernous sinus with gel foam and the inferior hypophyseal. I like to divide the dorsum in two in order to remove the clinoids. I think that's much less traumatic on the posterior gland and much more manageable. And eventually dividing the superior intercavernous sinus and dividing it, opening the precharismatic cistern. Now you have to be very careful here not to, when you take the inferior hypophyseals, to make sure that you don't take the superior hypophyseals as well. So we're being very careful here to avoid injury to them. Eventually making our way with a dural opening all the way down, making sure we don't hurt 6. And eventually starting to go towards the lesion, which gives it, we have an opening here essentially between the PCA and the SCA. And here you start to see it a little bit better. You see how flattened the third nerve is, and essentially kind of draped over the hematoma here. You can see the PCA and the PCOM hooking in. Forward now, but I still wasn't convinced that this was an aneurysm, so we did an ICG run one more time and got some of the clot out, and then we're looking at what we thought was the more solid components, which was the more sticky stuff back here. We eventually got that. This was the final one. So the patient did have some transient DI requiring a couple of doses of DDAVP, but that got better. His third nerve, he could open his eye slightly even by the time he was discharged home. And at 3 months, he could open his eye, and his third nerve was a little bit better, but it was still not entirely better. So this was the case.
Comments from the panelists or the speakers? Dr. Shekhar, is this?
I think it's a very nice and elegant operation, in my opinion. Certainly in my hands, a long ride for a short result. I'd be there with the in and out within 3 hours. But what you do best is the way. There's no one good highway. I think that with an extended transarterial approach, you could have gotten there very quickly and seen all the structures. In case you damage something, you can deal with them and so forth. But you are very experienced, and you are in a place which has some great pedigree and fantastic, very good, nice view and nice result.
Dr. Shekhar, you started everything here, so
that's why I said pedigree.
You're a living legend. And by the way, Lois, our master skull-based nurse, made me promise I would say hi tonight.
Thank you, and say hello to her and to all my colleagues in Pittsburgh, especially Carl Snyderman, whom I kept bugging every Wednesday.
Tiet and Torsten, is this done in Europe? Who does this I mean, who do you think would remove a brainstem cavernoma endonasally in Europe? You're muted.
No, I think I agree with Sheikh that it appears so much easier to do it via craniectomy. I'm not sure who would do it. Maybe Sebastian uses these approaches.
I still I don't think he would do it for this case. But
how about the Italians?
Look, Cavallo.
Yeah. But I think you did a nice job. I had one pontine lesion which really presented anteriorly. I went through endoscopic transclival approach. You know, it worked out very well. But I really think that the mastery of your institution is very important. I mean, you feel 100% safe in your place and with your training. That's very important. Yeah.
Well, my main concern was able again to be. I thought that Transylvian was my first thought, and what kind of swayed me a little bit away was the part that I would have to retract the PCA significantly to be looking up and look at that upper dome and see exactly where there's something there or not. It would have been in blind spot, and that's the reason I didn't do it. Not necessarily. I thought this was a little bit on the unconventional side in the beginning, but ultimately we decided to do it.
Well, it's a nice change from the other cases we've discussed. So let me finish it up with, there are only about 2 or 3 questions left. So I'll quickly ask. Sheikh, this is a question from your good friend, Walter Jean. Yeah. Dr. Shaker, when you say you prep for bypass, how far do you go for the preparation? When you needed that emergency bypass in the ossified tumor, did you have the graft harvested? And when the chance of bypass is low and ICA injury is encountered, how do you harvest the graft?
So those are very good questions. So everything depends on what is the level of expectation of injury. So we always have vascular imaging, you know, both radial artery and saphenous vein. If in that case, I kind of was expecting something because of it's a hard tumor, was encasing and so forth. But in one case, I distinctly remember we were not expecting anything and there was an injury. We emergently harvested the radial artery with, you know, temporary clips on and so forth. You know, I think you should always have proximal and distal control while you're working on the cavernous sinus, and also do try some local repair. I think that's always, we shouldn't discount that, you know, but if possible, if you think chance of bypass is high, we keep the patient on aspirin. If they are allergic to aspirin, nowadays we also put them on clopidogrel, and we get a verify now test beforehand. And almost all patients with vascular injuries, there are exceptions being young patients with very good collaterals. They seem to tolerate it pretty well. But anybody, young means less than 45. Anyone else, you know, we tend to do a bypass, you know, give them the benefit of doubt. Yeah.
The final question from the audience is, I'll open it to anybody who wants to answer it. Use of cranial nerve monitoring during cavernoma sinus surgery, if you use it, and how does it change your intraoperative management? And anybody can answer.
Well, as you know, I, along with Augie Moeller, described it first. I think the monitoring is much more sophisticated now. If you have a good team, that's the most important thing. I think Torsten was mentioning this. They clearly have a very well-refined team. If you don't have a good team, it doesn't help you. But if you have a good team, you know, putting the electrodes in the right places, et cetera, that's very important. You know, if they don't know what they're doing, you might as well do it without. They rely on anatomical. Torsten obviously is somebody who can answer this very well.
I agree. I must confess I put needles myself, being a control freak. So but unless you can trust and really trust your recordings, is that they are more dangerous than or harmful than abuse. Especially the trochlear is difficult because you have movement of the skin, and sometimes you have good monitoring, and then you lose it over time during your surgery. I'm not sure if I find the monitoring itself as helpful as the mapping function. You know, one is the surveillance and one is the finding where they are. And for me, the mapping is the most important thing.
I agree with you. That's how I use them in the cavernous sinus. I agree, to find the nerves. Anybody else wants to make any comments? It's 7:30. Go ahead, sorry.
I think it's very important what Sekhar said. We should have a team. It's very important to, in my department, the guy who is making this monitoring is neurosurgeon, is a neurosurgeon. And he is very experienced. And I think it is very important to work together as a team.
Anybody else?
So one more word, Jacques. Really like to thank you for putting together this outstanding panel and asking the right pimping questions. But one thing we need to really emphasize is the teamwork. And it's nice to have what impressed me a couple of times that I visited Curitiba is how Dr. Ramina has assembled a wonderful team in a private institute, you know, and something that is envious for even university-based neurosurgeons. So it's really nice to see that, you know.
On this word, then, I bid my European friends good night. I really thank you for staying up with us here. I thank everybody for participating, making this a fantastic session. The audience who stuck with us till 7:38 p.m. To all of you, good evening. Thank you so much.
Bye-bye.
Good night.
Bye-bye.